Okay, so hopefully everyone is having a good Tuesday. I know it's an afternoon time, so there would be a bit of a slum, but I'll try to make it quick, precise, and hopefully interesting. So my presentation is about a chronic diarrhea in elderly. Now, that's a really common problem that we're witnessing. It's almost like chronic cough, which is quite easy to, I would say, get a history, diagnose, but very hard to treat because we never really find out or narrow down the cause correctly. So this is one of the case presentation we had. That's the content of the presentation. So we're going to go through history, and then I'm going to talk a little bit about chronic diarrhea, and then we'll go back into the case and have a discussion. So we have an 89-year-old gentleman who presented to us with initial symptoms on an acute take with general fatigue, dehydration, increased frequency of loose stools, and as a consequence, he was lightheaded and he presented as a pre-syncopal case. So a simple episodic timeline for him was he's had loose stools for the last 18 months. There was no history of clear weight loss, no fever, no travel history. And the only positive finding at that time was he had an AKI grade 1 on admission with hyponatremia and hypokalemia, which was further treated with some IV fluids, and it was responsive. So this is just the initial presentation. I am going to go into a little bit about chronic diarrhea. So chronic diarrhea is defined as the decrease in stool consistency for more than 4 to 6 weeks usually, and it can present as a challenging scenario. Majority of the European population of elderly do witness or experience chronic diarrhea in about 3 to 5% of people, and it is a diagnostic challenge because there are several precipitants or several factors that can contribute to this condition. So some of the common ones that I've mentioned here are you could have an infective element, which could be viral or bacterial. You could have intolerance to food, certain medications, definitely intestinal diseases, some types of malignancies, and endocrine diseases. The most common presentation with our elderly patients is the use of or misuse of laxatives, fecal impaction leading to overflow diarrhea. And the other common presentation nowadays is, since they're getting tested more often, is celiac disease, if we cannot find out any other cause in these patients. So coming to the classification of diarrhea, it can, because it's caused by multiple factors, it's an easy way to delineate between an osmotic diarrhea, which is mostly lactase deficiency. You can have secretory diarrhea, which is an intestinal wall damage, or you can have motility diarrhea, which is decrease in the contact time of fecal mass and decrease in water absorption, which is one of the causes in our elderly related to aging. And the other would be disorders like IBS, gastric or intestinal surgeries that the patient has had. This slide looks quite busy, but it's just some key recommendation for primary practitioners along with us in hospital to sort of delineate the different causes that we can think. So if someone presents with chronic diarrhea, you want to first assess and divide them. Is this a secretory, osmotic, functional, or inflammatory? The second, they've mentioned the use of fecal osmotic gap, which we don't really use in our normal practice. It might be maybe gastroenterologists could share some light on it. Most persons with IBS would need to be assessed with the Rome's criteria and then colonoscopy, fecal calprotectin, which is normally ordered in our initial blood test, and a test for celiac disease in our patients, such as ordering a TDG. With iron deficiency profile, if patient has that, getting a HbA1c, and also basic liver function tests. The next slide is basically a good, it looks a bit busy, but it's a flow chart which basically goes in and establishes a very good history, duration, along with physical examination, initial blood test that we need to order, along with stool cultures to look for any sort of infective element. And the most common ones presenting to us are C. diff carriers because of overuse of antibiotics and laxative screen before going in towards procedures and investigations. And this also divides into assess what other things that we can look into, such as if they are fatty, watery, inflammatory. Is everyone on board with this? Can you see it?
We can enlarge it, Mariya.
I will try to see if I can.
No, you can enlarge everyone on the screen with their
Oh,
finger.
they can enlarge it. Okay,
yeah,
great.
they can. Yeah, for example,
Fine.
I've enlarged it and you can see it properly.
That's fine. Yeah. So I won't go through the whole thing, but this is what in basic it is to help you differentiate and understand the different kind of diarrhea pattern that can present. Because it is impractical to treat every cause that is there. So it's better if with our clinical judgment history, we're able to find plausible causes and then direct our investigations towards a diagnosis. So coming back to our patient, he had a past medical history of osteoarthritis, degenerative disc disease, bronchiectasis, basal cell carcinoma, angina, hypertension, benign prostate hyperplasia, and diverticulitis in the background. Coming to our favorite part as being in geriatrics, which is medications. Now, this gentleman had a whole lot of medication, as you can see. He was definitely finding very difficult to take them because he was finding very difficult to manage his symptoms because he was taking so many medications and he was having constant increased frequency of his stools. So the medications that you can see over here are bisoprolol, so a beta blocker, PPIs, statins. He had some mucolytics, antihypertensives, diuretics, vitamin D supplements, inhalers, anticoagulation, antiplatelets, and a few more diuretics and antihypertensives. So I just want you guys to have a good look at these medications because we will be sort of assessing them and further having a discussion on this.
Does anyone, before you go on, Mariya, anyone want to shout out, looking at this list, which medications or medication jumping onto you in terms of being a cause of chronic diarrhea?
Or anyone just thinks that they could cause diarrhea. Let's not even go chronic. Anyone just thinks starting a patient on any of these medications that you need to advise them that it could have a laxative effect or diarrhea.
Come on, guys, wakey, participate. We will be asking you questions.
I think they're still in a lunch slum.
Can somebody maybe type their answers? Surely we have enough people here. Can somebody type an answer? Out of all these medications, can you think of at least one which is implicated in chronic diarrhea? I mean, clearly this gentleman, you saw his past medical history. He does have diverticulitis, diverticulosis, which is another common cause of diarrhea. But in terms of medications, and you know how in geriatrics we love the word multifactorial, and his diarrhea is multifactorial. In geriatrics, in elderly people, diarrheas are multifactorial too. So I can see quite a few people typed PPI. Well done.
Okay,
so
good.
Definitely PPIs are notorious cause of chronic diarrhea. Go on, Mariya.
Okay, so that could be one of the culprits that we can see here. So let's go forward. Now, getting into a bit detail of the case presentation. So initially when he was assessed, he was hemodynamically fairly stable. There was no temperature. The only positive finding on his physical examination was a right iliac fossa pain, no stigmata of liver disease, with no obvious guarding or reduced bowel sounds. And his lab findings showed a stage 1 AKI on biochemistry, which was fairly responsive to IV fluids. And interestingly, his initial stool culture showed Shigella, but the PCR following that was negative for C. diff and Shigella. So any thoughts at the moment? How would you proceed for this patient now? What is the next investigation you would like, or any other questions you would like to ask?
And diarrhea, just to remind, the diarrhea is ongoing. He's been to hospital with us, what, for a couple of weeks now, hasn't he?
Yeah, so he presented almost 14 days.
14 days, yeah. So what shall we do next then? I definitely gave a call to Dr. Fong.
Yeah, well, I was going to get the I would say early involvement of gastroenterologists, but before the gastroenterologists get involved, we need to do a few more tests or investigations so they can proceed and provide us the advice. Okay, so now a CT abdomen was done, which showed a 20 centimeter distal colitis of possible infective source or late presentation of ulcerative colitis. Now, if you actually go back after seeing the CT abdomen report, I actually went back to the patient to actually ask for any other symptoms, which initially probably I would have missed or didn't assess in the past medical history. But he didn't have any other systemic presentation of a colitis. So there was no rashes, no obvious changes in his weight, no changes in his skin. The only thing he did have is polyarthritis, but that was joint pain that was persistent for years for him. Now, with that CT abdomen finding, we also saw that he had mild raised CRP and white cells. So his case was discussed with microbiology. They advised for ciprofloxacin for 5 days, which patient did have some marginal improvement in the frequency of his stools. Instead of having 6 times per day, it was reduced to about 4 to 5 times per day, but still quite debilitating for him. So gastroenterologists were consulted. It was found out that his GP had done a fit test for him initially, and he was awaiting a 2-week pathway assessment. He was then referred for a flexi-sig or a colonoscopy. The flexi-sig was not that exciting. It just showed some diverticulosis, and routine biopsy was taken. Nothing consistent signifying his symptoms. So holding on to that CT abdomen report and the sigmoidoscopy, what do you guys think, or what would you like to do further?
I think with ulcerative colitis, you know, that picture of colitis possible, which was shown on CT abdomen, we do need to remind ourselves that this diarrhea has been going on for 18 months now. And I think with untreated inflammatory ulcerative colitis or Crohn's, you would have had some complications by now, and you would have had much sicker patient. So colonoscopy, somebody's saying to do colonoscopy.
Okay, yeah, we could, but I think the flexi-sig didn't show anything significant, so he wasn't really further investigated with colonoscopy. It would be in the plan, surely. And the patient also was systemically quite well, apart from the diarrhea. So, despite the appropriate workup investigation, he was quite distressed with it, with his diarrhea. His AKI had improved. He was systemically well. And hence, as Dr. Mucci said, our favorite work is to assess, then going back to our medications to see anything was a culprit in that. So one of you or all of you have assessed PPI as one of the causes, and that was our thought process as well. So patient had a bit of deep prescribing done. His few of the medications I've documented here, his aspirin was changed as he was on Pixaban, amiodarone was stopped because he had bradycardia, furosemide because he was already on co-amilofruze, olmesartan and lansoprazole. Now, just keep that in mind because we were thinking about PPIs as well, but there's also another drug in this which could be a culprit, and we'll talk about it. He was then followed up in the clinic when he said that his bowel habit was improving gradually. He still did have episodes of diarrhea, but it was getting better, and he was getting better in himself. He was referred back to his GP to assess improvement of his diarrhea and then follow up with gastroenterology. Now, in the interim, there was the biopsy reports that came back. Because he had a routine biopsy done, nothing diagnostic, the biopsy showed lymphocytic or collagenous colitis with no malignancy. So this was a bit of a hiccup that came up because it didn't make sense. He had ulcerative colitis on the CT, plexisig didn't show as much, but the biopsy did show a lymphocytic or a collagenous colitis picture. So we went back to do a bit of reading that Dr. Mucci basically, I think, if you correct me, Dr. Mucci, you had read about a case that sort of had a similar presentation with one of the drugs. And
Mariya, I was on a conference about
yeah,
15 years ago where
okay,
a case presentation was made. And I remembered from then, and I thought, could this be that?
yeah. So I'm
That's the
glad for your
background.
memory. It was sort of like a moment of excitement because we could figure out something for the patient, and hence you can see already the medications that were deprescribed. So PPI could have been one culprit, but the other less known fact or less known cases that have been there are associated with olmesartan. So if I go back to the history of olmesartan, 2008 to 2011, there was a large influx of olmesartan use. About 10.6 billion population was given olmesartan for antihypertensive effects. Now, the lesser known fact was that all these patients were presenting with diarrhea, but more in a chronic presentation, mostly 6 to 12 months up to 2 years of using olmesartan alone or in combination. There was the first study that was done in, I think it was in Japan, if I correct, it was in 2012, fairly recently, where they found earliest evidence of olmesartan-induced Pru-like enteropathy. However, there were further few cases which were associated with a combination of sprue-like enteropathy along with collagenous colitis. And in these cohort of patients, the discontinuation of olmesartan showed significant improvement in 3 months in the histopathology of the gut, along with the 12-month complete resolution of the symptoms, along with a clean, good colon. So this was quite remarkable, and olmesartan is approved by FDA in 2002. It's one of the several ARBs that are used for hypertension. It has been associated with development of villus atrophy. So any patients that you're expecting chronic diarrhea definitely needs to be assessed for celiac disease because that can also have villus atrophy. And then consider olmesartan as one of the causes because a simple deprescribing made a huge difference in this patient's presentation. The FDA's warning for this medication is associated with severe and chronic diarrhea along with weight loss. So any of us as physicians, when we prescribe it, if we ever do, we need to make the patient aware and keep a patient under a good eye for this. And the importance of polypharmacy review is always handy. Any questions? Or anything that you guys were aware of this before? This was something we found new, and hence we thought we'll bring it to the audience.
You certainly hear about this on the conferences and, about all these rare cases, and you get so super excited hearing about something new. And you don't think, how often do you see it in clinical practice, one of these really rare presentations? And I have to say, this was one of them. This guy was, in fact, followed up in my clinic, not in gastroenterology. He had a phone consultation with me. And it was probably one of the most exciting consultations I've had for a long time because he picked up the phone and he was like, "Doctor, you cured me. I don't know what you've done. It's amazing. I have no diarrhea." And, as a geriatrician, I very rarely cure anyone. But I do find in clinical practice that stopping one or two drugs can be actually transformational for patients. There are other drugs to mention, again, from a geriatric perspective, is metformin. So metformin can cause diarrhea, and I cure at least one or two cases of long-standing chronic diarrhea in the patients on metformin, just discontinuing that. Any questions at all, guys, about this patient or chronic diarrhea in general? I can see Carrie, our frailty pharmacist, is online here as well. Carrie, any feedback? You are very experienced as well in this matter. Can you mention any other medications which you have come across? So we've mentioned the notorious ones, lansoprazole, PPIs, everyone knows about them. We mentioned metformin, which is quite well known. We now told you about the more rare one, olmesartan.
To consider, in case the patient has that.
Yeah, I would certainly say, I mean, olmesartan, it's something that there was in the back of my mind that there was an issue with it, but I would have definitely had to have done a lot of research to find that.
Yeah, I was really surprised actually when Dr. Mucci mentioned to me, we said we will deprescribe and see if it actually makes a difference. So I went back to read about it, and there were 23 cases. There aren't that many. There are only 23 cases with olmesartan, and most of them were in Europe and Asia. So we didn't really have obvious UK studies that were done. And this was one of the cases that we thought would be really good. I think with this patient, probably a follow-up histopathology review would be great to actually see the complete resolution and proving that this probably was the culprit.
And in terms of other management of the chronic diarrhea, just to share my experiences, when they come to my clinic, usually they come after they've had all their colonoscopies and investigations and this and that, seeing gastroenterology, GP is running out of ideas. So I go into a simple common sense, let's do a lactose-free diet. Let's do a celiac screen. Even there is a research out there which says that even in the patients who tested negative for celiac, when they go on a gluten-free diet, diarrhea gets better. So you just start experimenting and trying that. Obviously, try lactose-free first, then try gluten-free, then try something else. You go step by step. And just another medication to mention, which is important in geriatrics, that's donepezil, right? Cholinesterase inhibitors, donepezil for dementia is quite notorious for causing chronic diarrhea as well. Again, if they need to take the drug, you either go for a lower dose or you just advise the family that it might eventually get better. But Mariya is right. It's important when you prescribe these drugs to warn the patients that the diarrhea might be an issue, because it can be quite distressing and out of the blue, it worries people. It's a counseling is important. And I think that's where our pharmacists come to do more in-depth counseling.
Is there any gastroenterologists in the house? Anyone would like to share a light of any sort of chronic diarrhea that they have dealt with or they've thought about this before? Or is this something in common practice that they have seen? Do we have any gastroenterologists? I can't see anyone. No.
Okay, then, guys. Well, thank you very much, Mariya. I hope you've write up the case. And I hope to see your case report in the paper soon.
Yeah, lovely. All right. Thank you, guys. Have a good afternoon. Okay, bye.
Thank you. Bye. Bye.
Bye.